function and how the changes in enzymes or missing enzymes can contribute to disease. And when we're thinking about molecular genetics, we are thinking about DNA, and at the level of genes, how changes in genes can cause genetic disease. So today we will not be focusing on the laboratory arm of medical genetics. That is a topic for a future lecture, but we will be talking about the clinical arm. So when you're thinking about clinical genetics, we're thinking about actual patient-facing genetics, and this can be in the setting of a clinic, in the hospital, a private clinic, so on. And again, clinical genetics can be divided into different categories. These four are the four major categories, and within them, there are also a lot of subspecialties. But cancer genetics, pediatric genetics, prenatal genetics, and adult genetics are four distinct areas under clinical genetics. So this is what we will be focusing on in our lecture today, and we will try to give you some examples as to what happens in each of these sort of different specialties of genetics. So before I turn to doing that, I just want to briefly go over how one becomes a genetic counselor here in the United States. As of now, so currently there is no official or formal, rather, genetic counseling training in Pakistan. So if someone wants to become a genetic counselor, they learn about genetic counseling as a career, it's not a degree that they can achieve there. However, PSMG is diligently working towards making that happen in the future. So keep your eyes and ears open for that. But currently in the United States and say in Canada and some other countries now across the world, a genetic counseling degree is obtained after someone achieves a bachelor's degree. So I had a 4 years bachelor's degree. My major, for example, was in genetics, but really your major can be in any biology subject or a social science like psychology or sociology or a related field. Then you apply for a master's program, and it's a 2 years master's program. And really the program focuses on molecular genetics and counseling techniques. So you learn the basic science and then sort of psychosocial counseling as well. As a part of the 2 year master's degree program, you have clinical rotations. And what that means is that you are practicing as a genetic counselor pretty much soon into the program, like after the first semester or after the first quarter. And you are rotating through the pediatrics clinic, adult clinics, the cancer clinics, other industry rotations, and depending on the program. There are about 37 programs here in the United States. Another significant component of the program is research. So every student has to have a research project, and within those 2 years, they need to complete their research project, and the goal is to finally publish their research thesis. And after you graduate from the program, you have to take certification exams that are offered through the ABGC, which is an acronym for the American Board of Genetic Counseling. And some states require licensure, so you have to apply for a license to practice. So again, after you have done all of these steps, then you can work as a genetic counselor in any of the different subspecialties or specialties that I described before. It can be in a clinical setting or a private setting or in a laboratory or industry setting. Now, training for a geneticist is a little bit more difficult and longer because you have to be a doctor for that. So first off, you start off with either an MBBS or an MD degree. After you complete medical school and you have that degree, then you enter a residency program. So it's 2 years of sort of a primary residency. So that can be in pediatrics or OB or internal medicine or pathology. And after you've done those 2 years, then you have to do genetics focused residency. So it's another 2 years. Some institutions like where I am at the University of Texas, they offer a combined program. So you're not really doing 2 years of say internal medicine or peds separately and then doing 2 years of genetics, but you can do it together. So there's a peds medical genetics combined program where you're doing it sort of intermingled. So you're on peds, then you're on genetics. After that, a lot of people go on to do a fellowship, and that can be in molecular genetics or pathology. And again, you need board certification from the American Board of Medical Genetics and Genomics in this case. And then similarly as to genetic counselors, you can work in different settings, academic, at a hospital setting, a private clinic, or in the industry. So what do medical geneticists do? So they are doctors, right? Their primary goal, like so many other doctors, is really to make a diagnosis and to provide risk assessment. So they meet with patients, and this is more in the clinical capacity, of course. They meet with patients and they try to figure out what's going on. They try to make a diagnosis. Oftentimes, really most of the times, they need to order genetic tests. So they order the appropriate genetic tests and then they help explain those results. They talk to patients and their families and again communicate the results and the prognosis and what basically that genetic disease means for their family. If there is treatment, and for a lot of genetic conditions there isn't necessarily a treatment, but then there's this whole group of genetic conditions, inborn errors of metabolism, in which there might be some sort of dietary restriction, or there might be treatment, enzyme replacement treatment. So they'll of course discuss that. And then the management of the disease and or its complications. So, you need to see specialists because this disease involves some problem with the heart or the kidneys. So they sort of manage their care, make sure they're receiving all of the therapies, interventions, surveillance that they need to. And besides the sort of clinical or patient-facing role, they also have public health initiatives that they might be involved in, education and research work. So again, what is genetic counseling? So I've told you how one becomes a genetic counselor, but once they've become a genetic counselor, what are they actually doing? Some of the roles really overlap with that of a geneticist in terms of helping families process and adapt to genetics information and really helping them both understand the scientific information and also helping them psychologically just to adapt with what information that has been provided to them, say, for example, a new diagnosis in the family. And they really just educate them about how a genetic disorder is inherited, the genetic testing that was done, again, talk about management, prevention, provide them with resources that might be beneficial to them, and help them make informed choices. So the roles of a geneticist and a genetic counselor overlap quite a bit, but they're also distinct in the sense that a geneticist is a medical doctor. So geneticist is the one that is performing a physical exam. A genetic counselor does not perform a physical exam. And sometimes in some clinics, they work very closely together. So I myself work in a general genetics clinic where we see both pediatric and adult patients, and I work hand in hand with a geneticist. So I do part of the session where I'm taking the medical history, doing the intake, getting the family history, making a family tree, and then I'm communicating all of that information to the geneticist, and then the geneticist will do a physical exam, talk a little bit about prognosis, and then we either may talk about genetic testing or results together, or I may do it depending on just the flow of the clinic. They're shared responsibilities. In some other settings, such as cancer settings, genetic counselors work more independently. They see patients on their own, and they might be working alongside an oncologist. In a prenatal setting, a genetic counselor might be working alongside a maternal fetal medicine specialist or an OB-GYN. So different clinics and different specialties require different roles from genetic counselors. So let me go back one step. So now I've told you what a genetic counselor does. A lot of what we do is explain genetics to families and patients. So I'm going to switch gears and I'm going to do just that. I'm going to give a little bit of background of genetics, and hopefully that sets the stage for some of the other case examples that we're going to present. So everyone here has, I feel like, some exposure to biology and has some background in biology. So I know you might know much more than this and be experts, but I'm still going to go over it so that if someone doesn't really remember, everyone is on the same page. So as you remember, we have, our body is made up of millions and trillions of cells. Inside the nucleus of each cell, we have our genetic information in the form of chromosomes. Chromosomes really are just a DNA that's been condensed up. This is showing you a strand of DNA, and along the DNA, it's showing you our genes. So genes are just units of information along the length of our DNA. And it's also showing you the nitrogenous bases, A, Cs, Ts, and genes that are making up the DNA. This is another picture of what our genome looks like. So all of our chromosomes combined make up our genome. So remember that humans have 23 pairs or 46 chromosomes inside each cell. The chromosomes are in pairs that are called homologous chromosomes, and one member of each of the pair of homologous chromosomes comes from the mother, the other member comes from the father. So that's why they occur in pairs. And we know that they're arranged by size. So number 1 is the largest and number 22 is the smallest. And then the 23rd pair are the sex chromosomes. And these are typically XX in females and XY in males. So this is just another similar picture to the one prior. It is showing a chromosome and the gene along the length of the chromosome. Genes are small segments of DNA that have different functions. Some, but not all of them, may provide the code for proteins, different proteins that again have different functions in our body. The easiest example that everyone really is familiar with is that everyone has the same genes along the length of their chromosomes, right? So everyone has a gene, have multiple genes that contribute to eye color, but we have different combinations of DNA on those genes, which are referred to as different alleles. So that's why all of us have different eye color or different skin color, hair color, so on, and also different types of health. So humans have anywhere between 20 and 25,000 genes. And as genes are passed down from a parent to a child, when these chromosomes are passed down, mutations or changes may occur in these genes. And sometimes these may be completely harmless, but other times they may result in some sort of genetic disease. So let's talk more about genetic disease or genetic defects. So if you look at the third point on this slide, single gene defects, that's what I just described to you, right? A change or a mutation in a gene that can lead to a defect. A disorder. So a mutation, really, the formal definition of the term mutation is a permanent change in the sequence of DNA, right? And all of us have so many changes between our DNAs, and that's why we are so different in the way we look, the way we act, and the way our health is. And so the majority of these changes are fine. They just make up the variation between human beings. But sometimes a change can take place that really affects the structure of the protein that then goes on to be formed from that gene. Changes that cause disease are referred to as pathogenic variants. So they're pathogenic because they're disease causing. While changes in or mutations in genes that don't result in disease, we refer to as benign. But so the types of genetic defects, again, single gene defects, that's the one I've been talking about, a change in a gene that's resulting in a particular condition. So thalassemia as an example, cystic fibrosis might be an example. So there are lots of different, Marfan syndrome might be an example. So lots of different conditions that can result with a change in a gene. Now these can be inherited. So you're inheriting it from a parent who is either a carrier or who is affected by that condition, or these can be de novo. And that is when it takes place in either the sperm cell or the egg cell, right? So it's new in the individual that has it. I'm sorry. Does someone make a comment?
No, you're good.
Okay. I don't know, someone was saying. So going back to the top of the list, we have chromosomal problems. So some types of genetic defects just have to do with chromosomes, right? So they can be an extra chromosome, missing chromosomes, and we'll talk about some examples of these, or there can be large missing pieces of these chromosomes that I just showed you. And the large pieces, big chunks missing that you can actually see when you do a karyotype or you get an image of these chromosomes. They can be translocations, a piece of one chromosome missing and attached to another chromosome. You can have contiguous gene defects. So these aren't large chunks of deletions or duplications, but these are smaller micro deletions or duplications on our chromosomes. And what these are doing really is that there's a bunch of genes in a small little region that's either being completely deleted or it is being duplicated. So there's missing or extra information in some of our genes. One gene, it can be as small as a part of a gene, or it can be a few genes. So I take that back. It's not one gene because that's a single gene defect. This is usually a few genes. And then the last is imprinting defects. And these really are epigenetic changes. And what I mean by epigenetic changes is these are not changes in the DNA themselves, but these are changes on top of a DNA. So an example would be methylation, which is either causing a gene to be silenced, or histone modifications that, again, are extremely changes, not the DNA themselves, but on top of the DNA. And these sometimes cause a genetic
Apu, mera lecture ho raha hai, na chalana.
I'm sorry, if you're not muted, can you please mute? Thank you. These can result, in certain conditions that are inherited in a parent of origin specific manner. And a good example of this is Prader-Willi syndrome, in which you will have the condition if you are missing your parental copy of the gene, or a parental location on chromosome 15, right? So it's either you have two maternal copies or you have a deletion in the paternal copy, or whatever reason. So this is an example of an imprinting defect. Again, this is going to be covered in more detail in a future lecture, so I don't want to spend too much time on it. So what I've talked about so far are that there are different types of genetic defects. There are chromosomal defects, there are contiguous gene defects, single gene defects, and imprinting defects. All of these defects are resulting in genetic disorders that then have a specific pattern of inheritance, right? Autosomal dominant, autosomal recessive, X-linked, or mitochondrial or multifactorial. Mind you, we haven't really talked about the DNA that's present in the mitochondria. I've only focused on the DNA that's present in the nucleus of our cells. But again, that's a topic for a later time. So when you're thinking of genetic disorders, we can think about, what is the actual defect that's causing it, genetic defect, or you can think about genetic disorders and define or divide them according to their patterns of inheritance. Is it dominant, is it recessive, so on. Another way to look at genetic disorders is, when is the age of onset, right? Is it happening, is it affecting the pregnancy? Is it affecting a young child or a toddler or a newborn, or is it affecting an adult? So with that, I'm going to start talking about the specific areas, and I'm starting with prenatal genetics. So in prenatal genetics, really, the people who are coming in to see prenatal genetic counselors are couples who are either pregnant or they might be planning a pregnancy, right? Some of the common indications that we see in this are women who are at an older age, because remember, the chances of a woman to have a baby with a chromosomal problem such as Down syndrome, trisomy 18 and trisomy 13, Turner syndrome, it increases with age. So if someone who is older is having a baby, they might want to know, what are the chances for me to have a baby, say, for Down syndrome? Or they're coming in because they have an abnormal screening result. So they've had a quad screen or a serum screening that is showing an increased risk for, say, a trisomy. They have a family history of a genetic condition. So they're coming in saying, there are multiple people born in my family who have intellectual disability or have a certain intellectual disability plus birth defects, or thalassemia runs in my family, so on and so forth. And, or you can have people that are coming in because they found an abnormality on ultrasound. And some people just want to know that, I recently found out I was pregnant. However, I was on carbamazepine, or I was on a certain medication that they are then concerned might affect the health of the pregnancy. So that is a teratogen. So any exposure during pregnancy that might cause a birth defect is what a teratogen is. So they come in for teratogen counseling. So some of the screening and diagnostic tools that are offered prenatally can be maternal screening. Again, this is when you are looking at proteins that are made by the placenta or by the baby that can be found in mother's blood. And a certain pattern in these different proteins can indicate either a high or a lower risk for genetic aneuploidies, such as Down syndrome. Non-invasive prenatal testing, this will be covered in a lot more detail in the prenatal lecture, but basically a short definition of this is when you can, it's a non-invasive test, meaning it's just a blood test for mom, and you're looking at baby's DNA that is floating in mother's blood. So you're actually quantifying that DNA, comparing it to like with a ratio to mother's DNA, and saying, oh, there's way more of chromosome 21. So we think that the baby might be affected by chromosome 21. Again, this is a screening test. It's not diagnostic. It's not definitive, but it gives you an increase, a higher or low risk. Then there's carrier screening. So carrier screening is just to find out if the parents are carriers for a certain genetic condition. Again, a good example is thalassemia. So if thalassemia either runs in the family, or if someone wants to know if they are carriers for autosomal recessive conditions, that puts their baby at a risk for developing it. Again, testing for specific familial disorders that we can do. And then ultrasound can be a screening test because you can find an ultrasound anomaly that may indicate that there is something going on with the pregnancy, but it may not be diagnostic. And the other column, ultrasound, is also diagnostic. Sometimes you can find enough anomalies on ultrasound, especially for skeletal dysplasias, maybe spina bifida, that can be diagnosed on an ultrasound. So it's diagnostic in some purposes. Other diagnostic tests include CVS and amniocentesis. These are invasive tests which we are going into the pregnancy and either getting amniotic fluid or a sample of the chorionic villus to actually test to see if baby is affected. So this is my case example. So this, an example of a case that we would see in a prenatal clinic here is a 36-year-old patient is referred to discuss an 18-week ultrasound finding of growth restriction. So the baby is not growing well, smaller than expected to be at 18 weeks, clenched fist. So you can, on ultrasound, this is a level 2 high-level ultrasound in which you can see that the baby's fists are are clenched. And you can see a brain finding called a choroid plexus cyst. And really all a choroid plexus cyst is a collection of fluid in the part of the brain, which is called the choroid plexus. So on its own, sometimes if you only see a choroid plexus cyst, like you only see this little sort of ball of fluid that you can see as the black circle in the ultrasound image I have there. If you see it on its own without anything else going on, then it's just, that's what it is. And it means absolutely nothing. It has no consequence, right? It's seen in 1 to 2% of normal babies as an isolated anomaly. And that's perfectly fine. However, if it's seen in conjunction with other ultrasound anomalies, then that creates a problem, right? So in this case, we did see other ultrasound anomalies. We saw that the baby isn't growing well, which means that might be something is wrong, and that the baby had clenched fists. So the one thing that we know about choroid plexus cysts is that when you see them with other findings, then it is the most common minor marker for trisomy 18. So we know that it's a marker for trisomy 18, then we see the other thing. So that's a reason for concern. So she comes in. So what do we do in the genetic counseling session? We provide what it means. We provide counseling for what it means to have the choroid plexus cyst. So we tell her that, you know, it may be, if it's isolated, it typically resolves on its own. In your case, we're seeing, you know, some other things as well. The baby's growth is smaller than expected, and the clenched fist. So here are your options. You know, this is what we can do to try to figure out if there really is something going on or not. We talk about the screening test. So that's the serum screening test, which is just, again, a blood test, which we're looking at, like AFP, UBE3A, and all of these different proteins that are being produced by the placenta. That is screening. It won't give us 100% yes or a no, right? It's not diagnostic. The other screening test that I briefly talked to you about was the NIPT, non-invasive prenatal testing or screening. Again, that's looking at not at the metabolites, but really it's looking at the DNA. And then we have diagnostic tests, which are the CVS and the amniocentesis. So in the end, she wanted to know definitively, so she got an amniocentesis, and this is a picture of just that. They're taking a little bit of fluid from around the baby and looking at DNA. And if you look at this karyotype that resulted from the amniocentesis, there's one difference in this karyotype that wouldn't be present in a karyotype that does not have a genetic condition, and that I have a little arrow there, so that is a clue, but there is a third copy of chromosome 18. So the karyotype came back as 47XY plus 18. There are 3 copies of chromosome 18, and this is a diagnosis of trisomy 18. It's also called Edwards syndrome, but in trisomy 18, we have an extra copy of chromosome 18. It occurs in about 1 in 5,000 live-born infants. It is a life-threatening condition. It presents with when the babies are born, low birth weight, a small abnormally shaped head. So the shape of the head isn't like it should be, small jaw and mouth, which is microretrognathia, clenched fist with overlapping fingers. It can affect heart defects. Lots of other organs can be involved as well, such as the kidney. They can have spina bifida, and they have intellectual disability. These are some pictures of baby. This is a picture of a baby who has trisomy 18. You will notice the clenched fist. Another thing you might notice are the feet. They're called rocker bottom feet. So you can see the shape of the feet is kind of circular. You can see the clenched fist with the overlapping fingers. And I have a picture of cleft lip, I'm sorry, but this sometimes also presents with cleft palate. So these are just some of the features you can see in a baby with trisomy 18. Prognosis isn't very good. Most of the affected individuals die either before birth or within the first month of life. Only a minority survive the first year of life. Breathing problems or apnea is a common cause of death. The other information we would provide them is, the chances of this happening again. This is an error that's taking place in meiosis. It's not something that's inherited from the parent. So really the chances of it happening again are not extremely high. It's about 1%. Maternal age does play a part in it. So if the mother's much older, then it might be a little bit higher than 1%. And lastly, we would provide resources, right? We would talk about the Trisomy 18 Foundation. Of course, the parents would be very upset in this case. So we would try to facilitate grief counseling if necessary and give them educational material. Okay, that is my part. And I'm going to hand it over to Dr. Ijaz, who's going to talk more about pediatric genetics.
Assalamu alaikum, everyone, and welcome to the talk. Thank you for spending your Sunday evening with us. My name is Dr. Ahmed, as you have heard, and Aisha, thank you for your kind introduction. Myla, for a great presentation so far. And this is a brief introduction to medical genetics, so there's no way we can cover the whole topic. So I will be very brief. I will briefly talk about why pediatric genetics is important, how it helps the patients. We will talk about a couple of cases, and then we will talk about cancer genetics, why is it important, and we will then talk about the needs assessment in Pakistan, and I see a lot of questions being posted about that in the chat box, and then we will wrap it up with question and answer sessions. So I will be very brief, and for genetics expert over here, they may feel that the information is inadequate about certain conditions, but again, it was just as an introduction. But we will have detailed lectures on pediatric genetics and cancer genetics and other genetics. So in those lectures, we will cover many different types of topics in much greater detail. With that, I'll start with the pediatric genetics on our next slide.
I'm sorry, I'm trying. It's just stuck for some reason. Hold on.
All right, so with the pediatric genetics, the big question that we ask is, what is a genetic syndrome?
Okay.
You may have heard the word genetic syndrome. So it's either a new or inherited genetic condition that can have any of the issues that are listed on the slide here. Patients may be referred in the newborn period, or patients may be referred when they're a little bit older in toddler age, or pediatric patients can be referred in adolescence. So in the newborn population, the common reason for referrals are if the baby is born and noted to have multiple congenital anomalies. They can be internal or external. In the internal congenital anomalies, you have brain defects, brain abnormalities, you have heart defects, or the child has kidney defect. So a combination of problem that is in a child that kind of alerts the physicians that something's not right with the child, and then they ask for pediatric geneticists to come and take a look at the child. Or the child may have dysmorphic features, and those dysmorphic features could be unusual face, or they could be abnormal ears or abnormal eyes, or they could have abnormal um, birthmarks on their skin, or they may have limb abnormalities, a missing finger or joint fingers, or short or long fingers. So it depends on whatever those dysmorphic features are. They will then call the clinical geneticist to come and take a look at the baby. And also if the baby is not doing well and is failure to thrive, has hypotonia, is not feeding very well, so they may suspect that the baby might have a metabolic problem going on. So those are the reasons which usually you see children in the newborn period. Later on, if the baby is not got at that time, then later on, if there are any developmental delays where the baby is not, say, walking or talking at the time when they should be, they fail to achieve their milestones, that's when you wonder if something's going on with the baby because something's just not right. Or they may achieve their milestones at the regular time, but they may regress later on. They may lose their speech or something that's just not right. Um, or they may have problems at school. They may have intellectual disability, they have behavioral issues, they may show aggression. So those are the things that you kind of wonder if there's something just not right with the baby. Uh, or the toddler. Or later on in life, there could be growth issues where there can be overgrowth. Somebody is growing more than they should be, or maybe they have short stature. So these are the general reasons why a child is referred to clinical genetics for an evaluation. Next slide. So why is it important? Why is the evaluation of pediatric genetic syndrome important? It's like a mystery. It's a medical mystery. Many times the doctors don't know what's going on with these children, and they want our help to try to figure it out. So it's trying to solve a mystery, and you have to gather clues and figure out what's going on so that you can give a proper diagnosis to these children. And as we all know, there are thousands of pediatric genetic syndromes, and it's very hard to know all of them. Some of them are much more common, and you're easily recognizable, and you can see them, and you know what. And sometimes you don't even need a geneticist to recognize those syndromes. But most of them have a combination of medical and abnormal features that you can see, and you're able to recognize a pattern there. Some of them are very rare and may only be diagnosed with just advanced genetic testing. There's no way that you can just look at that child and say this is what he has, because pretty much you don't get any clues out of it. But the most important thing to understand that even after all of this, many of these children remain undiagnosed. We still don't know what it is. And with the newer genetic testing, things have gotten better. We are diagnosing more patients. But still, there's a subset of patients that we do not diagnose. So about 45% of the patients who present to the genetics clinic are, can you go back to the previous slide, please? Can we go back to the previous slide, please, Myla? Thank you. So
Is it this one? Yeah.
yeah, this is the one. Thank you. So many of them still remain undiagnosed. The important thing that whenever you're seeing a child with a genetic syndrome, is to get as much information about the medical history. And the medical history starts from when the mother was pregnant with the child. The prenatal history: was mother exposed to any teratogens? Was she taking any medicines that may have contributed to the congenital anomalies? You talk about the perinatal history. If there was prematurity, if there was a difficult labor that may have caused hypoxic injury to the brain. Later on, you talk about the medical problems that occur when the child is, after the child is born, if they had any issues such as hypoglycemia or failure to thrive. Later on, developmental history is important in terms of trying to find out if they had any delays, if they had speech delays, if they had motor delays, if they had intellectual disability. Um, Family history is very important, of course, because the family history, the age of the parents gives us a clue. If there's some advanced maternal age, we would suspect that there might be a chromosomal problem. With advanced paternal age, sometimes there are point mutations. If there's consanguinity in the family, then you'll think of autosomal recessive disorders. Or if there's a known problem in the family, then you're thinking about autosomal dominant conditions. Certain ethnicities, especially in US, we know that certain ethnicities have certain genetic problems. We don't know much about the Pakistani population at this time, but this is an important thing. So family history and medical history is very important. After that, of course, comes the physical examination, where you basically take a look at the child. Try to see if the child looks abnormal, if the child looks peculiar. Does it resemble certain genetic syndrome that you can think of? You look at the head size, you look at the facial features, you measure the limbs, you look at their fingers, their toes, you look at their skin to see if there are any birthmarks. You look at the genitalia to see if there's any ambiguity in the genitalia. So physical exam also will give you many different clues. So based on the medical history, family history, physical examination, you come up with a set of provisional diagnoses. You say, okay, maybe this is what this is. Sometimes you know exactly what it is. Sometimes you're like, maybe this is what's going on. And you have a set of differential there. And then you talk to the family, explain them what you think is going on, and then you order genetic testing. Genetic testing, you can either order targeted genetic testing when you pretty much know what it is. Like if you're seeing a child with chromosome abnormality, you know it, you order that test. But if you don't, you may decide to order a chromosomal microarray, which would look at all deletions and duplications within the chromosomes. Uh, and if you think that that's not what's going on, it's a single gene defect, a recessive disorder, then you may order a single gene testing or maybe a multi-gene panel testing, which may include either a exome slice, as we call it, where it's just a targeted multi-gene panel, or we can expand it to test for many thousands of genes with the whole exome sequence. So that's basically the way you evaluate a child with a pediatric genetic syndrome. Next slide, please. Thank you. So why is it important? A lot of people say, well, you know what, if child has a genetic problem, then they have a genetic problem. There's nothing that you can do to take it away. You can't cure it. Then why even try to find it out? So many times these children are just lumped as having um, special needs children or mentally retarded kids or some word that is used for them, and they just are special needs kid, and that they are just lumped into that. But it's very important to find out exactly what's going on, because knowing what that condition is would help us know if there are any medical problems that are associated with that condition. Some conditions have heart defects, some have endocrine problems, some have um, you know, developmental issues going on. So knowing exactly what it is would help the clinicians look for certain things, look for certain problems and anticipate certain problems and do proper management for that patient. Uh, some conditions are associated with significant intellectual disability or developmental delay. So if we know that, we can institute occupational therapy, physical therapy, speech therapy in advance. We may put those children in special education because that helps, you know, help them with maximizing their potential. And the most important factor here is actually information to the family. It's very important for the family to know what's wrong with the child. Many times parents are just looking for an answer. So it's important that the, you know, make a proper diagnosis with the genetic testing. It brings closure to the family. They can be part of support groups and not feel alone, and then they pretty much understand what their child has and what to anticipate. Uh, it also helps identifying another family member who may be at risk. They may have a baby who's born, and that baby may also get that condition later on. So knowing what their child has helps them or alleviate their anxiety about their newborn baby, to see if that baby has that condition or not. So it's very helpful for the family to make a proper genetic diagnosis. And of course, last but not the least, it helps families to understand the recurrence risk, and then they can do family planning accordingly. Um, Next slide. So I'm just giving you a couple of examples. I'm sure you must all know someone in your family or in your friends who has a child with Down syndrome. This is a very common condition, and that is something that you really don't need a geneticist or genetic counselor or any genetic expert to make the diagnosis. Sometimes you can see these children in school or street, and you know, I know that what this child has. And this is a very common condition, most common chromosomal abnormality, I would say, uh, as Down syndrome. And there are certain physical features, and no matter where these children are across the world, you just see them and you know what they look like and you know what their genetic condition is. Significant facial features, you can see their eyes are up slanting. They have a flattened nasal bridge. Because they have a flattened nasal bridge, their lacrimal ducts are sometimes blocked, and that is why you can see the tearing, extra tearing in these eyes. Um, they have low set posterior rotated ears. They may have increased skin on the back of their neck. You can see in the upper photo, they may or may not have a transverse palmar crease, which is a clue. And they may have you can see the fifth finger, the pinky, which is small and it's curved. It's called fifth finger clinodactyly. That's something that you see commonly. And another interesting thing is that they have this sandal toe deformity. If you can see the space between the great toe and second toe. So that those are little clues when you call to the NICU to see a baby and they think maybe the baby has Down syndrome. So you can look at these certain things and make a diagnosis early. Of course, you can do genetic testing and find out what the genetic change is. Next slide, please. Um, we all know that this is trisomy 21. They have an extra chromosome 21. Interestingly, all these
वो लड़का
children,
गिर जाएगा ओ
अगर आप please mute कर लें अपने आप को, that would be good. Thank you. So they have an extra chromosome 21, and we know that most of these children, even though they have the same genetic condition, they don't have the same medical issues. Some of them may have heart defects, some may not have heart defects, some may have significant vision problems, some may not, some may have hearing loss, thyroid abnormalities, constipation. Some of these children may get leukemias earlier in life. So there are certain conditions that are associated with this condition. So that's why I'm going back to my previous slides where I said it's very important to know what it is. This is just a very simple example, but you can have medical problem. You may anticipate developmental delays in these children, so you institute therapies early. We know that these children have moderate to severe intellectual disability. Some are pretty high functioning, but many of them are. And I'm not getting into the mosaic Down syndrome and all of that stuff. But this is important to understand that these problems can happen in these children, and of course, it's helpful for the family to know that because it's a chromosomal aneuploidy, the recurrence risk is low, other than for maternal age risk plus 1%. I'm not talking about the translocation Down syndrome, which is a different type of Down syndrome, which has a higher recurrence risk. But generally, with the trisomy 21, the recurrence risk is low for the family. So this is very good information from the families to know. Next slide. Um, just another example of another condition, which is a single gene defect, where uh, a condition called Fragile X syndrome, and some of you may have seen patients with this condition, or you may have seen them and you didn't realize that that's what they have. This is a very common cause of intellectual disability in the here in the U.S. is 1 in 4,000 and 1 in 8,000 males and 1 in 8,000 females. Usually, these children present earlier in toddler age with speech and language delays, mild to moderate intellectual disability. They have hyperactivity. They are not doing well in school. The teachers are very upset with them. Some of them like exhibit autistic features where they don't make good eye contact and they do repetitive behaviors. Um, they don't have major medical problems. So this is an example where you don't have to really worry about medical problems. That's why these children are not even noted till the time they're older. But they have distinct clinical facial features that you can see for a trained geneticist or for a trained eye. They can look at it. You can see a prominent forehead there. You can see large ears that are protruded, um, and they have a prominent jaw and the white space teeth. So those are the findings, that subtle finding. When we have a child who have all these problems and they look like this, then you can say, well, yeah, this is probably what's going on here is Fragile X syndrome. So we can order testing for that and find out. Next slide. The interesting thing about these children is that these are the same individuals. So in their young age and in their older life, and when they're children, sometimes the features can be very subtle and you may not recognize it unless you are trained. But as they grow older, their facial features become more prominent. You can see the long and narrow face, you can see the large ears, you can see the prominent jaw and forehead. Usually they have flexible fingers, they have flat feet. Well, a lot of people have flat feet, but they also, one of the finding in these individuals is that they have enlarged testicles, the macroorchidism, which you can see after puberty. So those are the findings, and even in the genetic condition, you can see the example where initially you may not catch it, but as time progresses, you may catch these genetic syndromes. Next slide. So interestingly, when you send the testing for this condition, this is caused by there's a CGG repeat in the 5' untranslated region of the FMR1 gene. And we all have certain number of CGG repeats, which are okay, 5 to 44. If you have those repeat size, then you're okay. You would not have any problems and you would have a normal protein. But if you have from 45 to 54, you still would be okay, but that can expand in future generations. But other than that, there's usually no problem. But when it goes from 55 to 200 repeats, that is considered pre-mutation. So when you have that, the RNA, there are many copies of RNA that don't work properly, and it is called pre-mutation. And interestingly, the pre-mutation presentation is very different from a full mutation. With the pre-mutation, women can have premature ovarian failure. Men who have pre-mutation may have a condition called fragile ataxia syndrome. So just having a pre-mutation gives them a different condition, and if they have greater than 200 repeats, then they may have full Fragile X syndrome. Because it's an X chromosome disorder, women, because they have two X chromosome, they are not as affected, but some of them may be, but many of the time, the boys are the ones, their male children who get this Fragile X from the mothers are the ones that have a full-blown syndrome. So next slide is important because it just shows a pedigree of X-linked disorder. Just to give an example that this is why it's important to find out, it helps other family members to know what it is. So this child who is a 6-year-old child has learning disability and hyperactivity at this time, has not been diagnosed with quote unquote intellectual disability, presented to the genetics clinic, suspected to have Fragile X test, and testing confirmed the diagnosis. You can see the mother also reported that she did have learning disability. She didn't do very well in school. And she also reported that she has a brother who has intellectual disability. So could be a dominant, but you think of X-linked conditions here, but not real dominant because the mother is doing okay. And if the mother would have 2 or 3 sisters, it's important for them to know if they are carriers as well, because then they can have children or boys who could be affected or daughters who could be carriers. So if you're a boy who has this, and if you do reproduce, then you can give this X chromosome to all your daughters, but your sons would not get it from them and they will be carriers. So that's how an X-linked disorder works. So I'll just quickly go on to the next slide. I know we're running short on time. As far as the hereditary cancer disorders are concerned, I'm just switching gears and just give you some examples of what is hereditary cancer. Basically, it's types of inherited disorder in which there is a higher than normal risk of certain type of cancer. This is a very important thing. It's higher than normal. We all have risk for cancer. Anybody can get any cancer. But in those families, the risk is higher. You have a more chance of getting that certain type of cancer. There are many, many genetic syndromes that have been defined, and this is beyond the scope of this lecture, and we will address that in another lecture. But important to distinguish is somatic versus germline mutations, because all cancers have genetic mutations in them, but that does not mean that it's inherited. Inherited mutations are in the germline, which predisposes them to have a cancer. So the cancer may also have that germline mutation because it's in every cell of their body, and many other changes. So somatic is within the cancer, germline is what you inherit from the parents. So that's important. And then there are some cancer syndromes that present in childhood. So that has to be, understood and be watchful of. So if even if there's childhood cancer, certain type of cancers could be due to a inherited genetic problem. But most of these disorders are in adulthood. Important to understand next slide that this is a small group of disorders. So about 5 to 10% of the overall cancers that happen in people are due to hereditary cause. There could be a 15 to 20% that could be family clusters. So there's a little bit more of that type of a cancer in that family that could be due to some environmental factors, some low penetrant genes, or the food that they eat, or something, or where they live, something that would increase their risk as far as the family clusters is concerned. But 70 to 80% is sporadic. Next slide. Um, so the common cancers that are associated with hereditary cancer syndromes include the breast cancer, ovarian cancer, pancreatic, prostate, colon, uterine, gastric, renal, melanomas. But in reality, there are all other different cancers that are there, like thyroid cancers and stuff like that. The big three are breast cancer, ovarian cancer, or colon cancer, or colon polyposis. They can be in combination with each other, with breast and ovarian cancer, or just breast cancer in the family by themselves, or ovarian cancer in the family by themselves. Colon can be in association with uterine cancers that will make us think about Lynch syndrome, or with other cancers. So this is very important that you look at these cancers and kind of say, okay, what's going on in this family, and try to recognize what genetic syndrome it is. But again, this is a very, very brief description. Next slide, please. So whenever we are talking about hereditary cancer syndrome, there are a few things that you have to try to figure out because that's very important. So age of onset is important. Certain cancers, like for instance, breast cancer or colon cancer, usually occur around 50 years or greater. But if there are cancers in the family that are happening in young individuals when they're in the 30s or 40s, which is unusual for that type of cancer, then you say, well, something's just not right. You also want to know the histological type of cancer. You want to know for ovarian cancer, is it a serous papillary carcinoma? Or, so that is an information that we really have to gather because there are different types of ovarian cancers like teratomas and things like that that can happen in early age and that may not be associated with a cancer syndrome. So getting a history is important. Age of onset, histological type. In multiple cancers in a person can also, they may have both breast and ovarian or uterine or they may have polyposis syndrome. So those are the things that makes us wonder if there is a problem. So age of onset, histological type, multiple cancers in a person, or even if they have some rare, unusual type of cancers. For instance, a man with breast cancer, that's not very common. If they have it, then you know that something's not right. If they have medullary thyroid cancer, then you know that is something that is associated with multiple endocrine neoplasia. If they have adrenocortical carcinoma, that's something that is associated with leishmania. So that is important to find out what exactly, and if they have a rare cancer, then you think about it. Family history is important, of course. Strong family history of cancer, like we already said, that is one of the most common indicator. Or if there's already a known genetic mutation in the family that the person comes up, we can then go ahead and test it. And certain ethnicity like Ashkenazi Jewish population is important to note. So those are the important factors that you have to consider when you're looking at the hereditary cancer syndrome that would help you give some clue. Why is it important to find out? Because it helps for clinicians to know what the surgical options are. If they have a genetic, say, hereditary breast and ovarian cancer, they may decide to have bilateral mastectomy. They may decide to have um, um, instead of going for a lumpectomy or radiation, they just go for having both of the breasts removed. It also helps finding out if they can be amenable to certain cancer treatment, like PARP inhibitors are used for patients who have homologous repair recombination defects. Um, if the patient is still unaffected, they may decide to have prophylactic surgery. So patients who have increased risk for certain cancers, they may go and have both their breast removed, or they may have their ovaries removed, or if they have familial adenomatous polyposis, they may, when they start making polyps, they can have all their colon removed or thyroid removed, depending. So it helps save them from cancer. So that's very important. So it helps them with the treatment and it helps save them from future cancers. Or if they decide they don't want to have surgery, they can then go under have high risk screening. They can have mammograms, they can have MRIs, they can have colonoscopies. So depending on what genetic condition, what genetic cancer syndrome it is, they can choose any of these options. And of course, the most important thing here is family cascade testing, where once you find out what the genetic problem is in that person, then you can test other family members who don't have cancer yet, and then they can find out what their risk for cancer is, if they are at risk for cancer, and then choose any of those high risk screening or prophylactic surgeries, or that may help them with family planning as well, because they have a cancer mutation. They may decide if they want to pass it on to their children or not. So all of those things are very important to note here. Next slide, please. So I'll just give you a quick example of, one of the famous BRCA BRCA patient. This is Angelina Jolie, famous US actor here. So she's 37 when she was evaluated, and her mother died of breast cancer and ovarian cancer at age 56. So you can see it's a pretty younger age. And then her aunt also had breast cancer at age 61. And then you can see her grandmother had ovarian cancer at 41. So you see three first-degree relatives, all of them with breast cancer or ovarian cancer. She herself did not have cancer, but she underwent genetic testing and found to have a BRCA one genetic mutation. And actually that was awakening call for the US population here, and we got inundated with referrals because everybody wanted to get tested because Angelina Jolie had this genetic change. So this is an example of breast and ovarian cancer, and now that she has three biological children, she could have a 50% chance of passing it to her children. So they can be tested when they're 18 and older. This is important to note that certain other genetic conditions, you don't test children for that. You wait till the time they're 18 and older. Next slide. So it's caused by mutations. The hereditary breast and ovarian cancer is caused by mutation in BRCA1 and BRCA2 genes. Uh, you have a pretty high risk for breast cancer, about 80%, which is very, very high, but that can have a range. And ovarian cancer can also have a 20 to 50% risk, but this could be different for the BRCA1 and BRCA2 genes. I just lumped them together. There could be risk for men who can have male prostate cancer. They can have male breast cancer. You can have pancreatic cancer. You can have melanoma. And it's important to understand that these cancer genes can come from mother and father. So you just can't concentrate on the mother side of the family. You have to talk about the father side of the family history as well. And I think I've talked about the management options they can have for mastectomy or high-risk screening. So I'll go to the next slide. So quickly about the needs assessment, and basically we are getting into the last part of our talk and the discussion part about it. We wanted to just bring it up. Next slide, please. Um, we know that genetic medicine is the future of medicine. In the US, since I started practicing in 15 years, it's just we are getting more and more and more involved with almost all different specialties. We haven't talked about cardiogenetics, we haven't talked about neurogenetics, we haven't talked about endocrine genetics. Almost all specialties are using genetic services for genetic testing, counseling. We are moving towards personalized medicine. We are doing pharmacogenomics. We are finding out what the person's genetic makeup is, and based on that, we are anticipating what genetic problems they may get, what medical problems they may get, what kind of treatment would be better for them. So this is the future of medicine, and we are moving there. And especially with the advanced genetic testing and the next generation sequencing, there are more and more genetic conditions that are being identified. So there's a greater need for this to be integrated into the medical practice. Next slide. So currently, we do not have a formal genetic counseling or postgraduate genetics training program in Pakistan, and that is what we are striving for. We have just started this whole process with these lectures. We are identifying clinics, and we are trying to find our laboratories who would help us with training the genetic students. So we don't have any program yet, but we do intend to come up with some program with collaboration from University of Health Sciences, from Medical, from Jinasan Medical University to try to set up a program which may be a certificate course, and we can go from there. Even the World Health Organization recognizes that these services are needed in Pakistan because we have a very high rate of consanguinity in Pakistan, so a higher rate of genetic disorders. We recently organized a webinar in December of 2020, and in that webinar, we asked our participants what do they think there is a need of genetics in Pakistan or not, and the next slide shows their responses. But basically what we have is almost 80 to 90 or 100% of the people said, yes, we do need genetic services in Pakistan. We need genetic training in Pakistan. So we are hoping to write up a paper about that webinar and bring it to the attention of other peoples as well. But today we have almost 97 participants on this call. So uh, I think we are gaining momentum, and with everybody's help, we can get to this issue and try to have some formal training both for doctors and for say for genetic counseling positions in Pakistan. Next slide. Uh, since we have started this process, we have already been contacted by many clinical laboratories in Pakistan and also clinicians in Pakistan who need help. They have patients who have genetic disorders. We have already started working with NICH. We already started working with South City Hospital with doing some teleclinics, and so there's a big opportunity for young students who are on the line to get into this field. Like hopefully this will be a big void that they can fill for themselves. Um, So basically, that's where we are with this, and I can open it for the discussions because we're 5 minutes over, and we can go from there. Aisha, you want to take over?
Yeah, thank you. Wonderful job, both of you. Such a insightful presentation. And we always go over time. That's Pakistani way. So why don't we jump right into the questions right away? So first of all, I guess either of you can take this question. Our audience is really excited about Pakistani Society of Medical Genetics, and they want to join the group. And their questions are, will PSMG be providing certifications for genetic counseling or any training workshops? And how can they join PSMG? So can you please give a quick response to that?
Sure, Myra, if you want to jump in anytime. Basically, like I said, we just started the process. It's just been a few months since being in it. So this is a whole idea that is blossoming. We are getting more momentum, and now with your participation, we don't have a certificate program at this time. We are striving to have something going on with our collaborators that we can start a process. So be on the lookout. Hopefully, we will start with these lecture series that would develop into a course that would develop into a certificate program for a more formal training. But as Myla told you, that this has to be either we do it right or we don't do it. So in order for us to do it right, we have to train people properly. And in order to train them, four of us are in the US, so we need people in Pakistan who would be help in teaching these patients, going through laboratory rotations, going through some type of genetic counseling program with certain, clinical sites. So all of that stuff is in working, and we're trying to come up with it, but nothing's there. As far as the PSMG is concerned, this is the website. Go on it. There's a site where you can send emails, get registered, and at least be part of the group. We'll keep sending you emails. This is nothing. There's no membership right now. There is no formal money is involved. You can just be part of this group to start the basically a collaboration with all of us.
Yeah, I would agree. I would just second that, that if you are interested in any future certification program, I think the best thing to do right now is go onto the website and fill out the contact me form, fill out the survey from today so that we have your contact information available. Because as we move forward and have these programs available, we will reach out to the people who have contacted us at the PSMG website first. So
And
you
in
will
the
know.
chat box, we have included a link, and all you do is you go to that link. It's a Google form link, and you fill out the form. और जब आप वो फिल कर लेंगे तो फिर हमें आपकी इन्फॉर्मेशन मिल जाएगी, और जब हमें आपकी इन्फॉर्मेशन मिल जाएगी तो हम जितने भी बाकी आइंदा आने वाले प्रोग्राम्स हैं उनके मुतालिक आपको इन्फॉर्मेशन भेजते रहेंगे इंशाल्लाह. Okay, next question is, all right, this is a difficult one, but let's see if we can take a stab at it. How are epigenetic genes defects diagnosed?
Okay.
Mara, you want to take it?
You wanna-
Okay, so basically, that's bisulfite methylation analysis that you can do for these. Basically, what you're looking at silencing of the genes. So, the commonest one that is done in our labs is the Prader-Willi and Angelman syndrome testing. So the bisulfite analysis, which is, and again, I'm not a laboratorian. Maybe somebody in the laboratory may have more proper answer to that, but there's methylation specific analysis that you can do to find out silencing of the genes. But I'm not aware of any multi-gene panels for methylation analysis. It has to be gene specific.
No.
Great. The next question that we have is about the number of genes. Are 2,000 to 20,000 to 25,000 unique genes, or including variations? So Myla, I think that's for you.
Sure. They are unique genes. So the estimate right now is about around 23,000 genes is what we know that the human genome has. So not the variations. If you think about the variations, then that goes into the millions. There are lots of genetic variations.
Okay, thank you. Next question is, can we go for medical genetics after doing a bachelor's degree in genetics, or there is a MBBS degree needed for medical genetics? So I think that they're trying to distinguish between medical geneticist, who is a doctor, versus a genetic counselor who is not a doctor but goes through a master's degree program. So I'll quickly just distinguish the two. So genetic counselor के लिए आपको 2 साल की पढ़ाई करनी होती है जो कि मास्टर्स डिग्री की होती है. उसके बाद आपको एक इम्तिहान देना होता है और उस इम्तिहान में अगर आप पास हो जाते हैं तो आपको सर्टिफिकेट मिल जाता है कि आप जेनेटिक काउंसलर बन गए हैं. उसके बाद आप कहीं भी प्रैक्टिस कर सकते हैं यूनाइटेड स्टेट्स के लिए. और अगर आपने जेनेटिसिस्ट बनना है जो कि मेडिकल जेनेटिक्स है, उनका वो डॉक्टर होता है, वो डॉक्टर के बाद पढ़ाई करते हैं फेलोशिप की और फिर उसके बाद उनको इम्तिहान देना पड़ता है एक बोर्ड एग्जाम का, फिर वो डॉक्टर बन जाते हैं जेनेटिक्स के, जैसे कि डॉक्टर एजाज हैं. तो ये मैं जल्दी से आगे बढ़ जाती हूँ. Do we find defects in shapes of chromosomes as well, not just missing or anything like that?
Yes, definitely. We find defects in the shape of chromosomes as well.
Okay, so next question is, are you planning to start a certificate course? If yes, then where at US or Pakistan? You must be planning for offering membership when it's going to happen. I think we kind of addressed that कि हमने बताया था कि अभी तो हमारे पास फुल फ्लैज मेंबरशिप जैसे पैसों वाली होती है वो नहीं है. अभी आप सिर्फ हमारा जो फॉर्म है वो फिल आउट कर लेंगे तो हमें आपकी इन्फॉर्मेशन मिल जाएगी, बस वही आपकी मेंबरशिप है. और जब पैसों का मुतालबा करने का वक्त आएगा तो हम आपसे फौरन मांग लेंगे और बिल्कुल नहीं हिचकिचाएंगे. तो अभी तो वहां तक नहीं पहुंचे हैं. और जहाँ तक सर्टिफिकेशन का कोर्स का ताल्लुक है, हमारा एम है कि 2022 में एक फुल फ्लैज कोर्स तब तक तैयार कर लेंगे जिसमें हम आपको बता देंगे कि किस यूनिवर्सिटी से है, किस तरह अप्लाई करना है, क्या क्राइटेरिया है. ये सारी बातें हम आपको उस वक्त जब हमारा पक्का हो जाएगा ना तो बता देंगे. ओके, एवरी short stature female or male are suspected for Turner's and need conventional cytogenetics. What is the role for doctors at that time when he or she refers a test, criteria for conventional cytogenetics for short stature in males and females? Ijaz?
Sure. If I understand this question properly, you're talking about Noonan syndrome, which is a counterpart male Turner syndrome. So what you do is basically, if you suspect if it's a female and she has physical features of Turner syndrome with short stature, you just order a chromosome analysis, and you will get an answer for that. If it's a negative and you still suspect, then you can think about Noonan syndrome, which is a common condition which has a lot of resemblance with Turner syndrome. And even in male patients, you can suspect that they may have Noonan syndrome. And uske liye, there's a set of testing which is separate. There are many different genes that are involved with Noonan syndrome. So you can order testing for that. So it's a clinical evaluation. You look at, like I said, family history, physical features and everything, and you try to make up diagnosis and order the proper testing. I'm not sure if I answered that question properly, or that's what the...
It was a broad question and difficult to answer when we have short on time. Okay, the Myla, next question I think is for you. Genetic screening is stigmatized in Pakistan. What genetic screening tests partners should go for before marriage, specifically when the partners are cousins?
That's a really good question. I think that the best test that cousins who are married to each other should go for is a carrier screening test. And that test will inform both husband and the wife if they are carriers for certain autosomal recessive conditions. Because when we're thinking about people who are related and being married, they have one ancestor in common, right? So the Nana might be the same, the Dada might be the same, or so on. So the chances of that person to have an allele for a rare recessive disorder and then passing it down to then the two cousins is much higher than what it would be just if two unrelated people are married. So for that reason, the best test is carrier screening. And you find out if you are a carrier, you find out if your spouse is a carrier. If you are, then you are educated about the risks of that specific condition and that there is a 25% chance that the baby might have that disorder. 75% chance that they might not. Take that answer.
Yeah, no, that's wonderful. Thank you. That was it. Okay. I guess Ajaz, you can take this one. What is the criteria for labeling sandal toe deformity?
There is no formal criteria or test. It's an observation that you see in a child. And sometimes you may have kids who are normal, may have the sandal toe deformity. So if you're thinking that, oh, your baby may have it too, it's not a deformity, it's just a sign. And a lot of babies have that too. So it's a very soft sign. So something that you see commonly in those children, but in no way that you see a sandal toe deformity in the baby and you say, yeah, that kid has Down syndrome. No, you have to have a combination of problems. So if you're thinking of someone that you know have a sandal toe deformity, don't be too worried about it. They don't have Down syndrome. It's a common finding, but something that you see very often.
Okay, the next question is about autism treatment. Maybe Jazz, you can take this one. They're asking if there is a behavioral management therapy.
एक और पेपर चाहिए है मैं कट करेंगे फिर
बंद कर दो प्लीज, ये म्यूट कर दो।
उसको हम टेप से
I think it's
बांधेंगे
Najwa.
Okay,
Okay, there you go.
Got it.
Najwa has been muted. Sorry, Najwa. Okay. तो जीन थेरेपी मौजूद है क्या ऑटिज्म के लिए, और सवाल पूछ रहे हैं कि except for behavioral management therapy, are there any medications for the disease for autism?
First of all, there is no medical cure that you just gave a medicine and that would take away the problem. Yes, some medicines are available that you can give to these patients if they have attention problems, that you can give medicines like Enderol and things like that, which helps them focus. But there is no medical treatment that you give this medicine and the autism goes away. There is mostly behavioral therapies and the therapies that these children go through, and those are the most helpful things for them. If they have certain psychiatric problems associated with that, that can help with, again, with medicine. But generally for these patients, therapies is the way to go.
Okay, very good. And then I guess the last question that we have is, when a genetic disease is diagnosed, how can we do genetic counseling in our clinic where genetic counselor is not available? Myla, do you have like, let's say 3 takeaways for a MBBS doctor who's seeing genetic diagnosis and wants to know, how can I counsel my patient? I don't have a genetic counselor in Pakistan right now. What do I do?
That's a good question. So I think that if you're able to if you have a diagnosis, say for instance, then you're working off of that diagnosis, and it's really just educating the patients about the condition they have, the prognosis, what they should expect, and explaining the genetics behind it. There are some good resources that we can suggest. Maybe we can even write them in the chat. There is a website that we often refer to as Gene Reviews that has really good information on really all of the genetic disorders, and it goes by section. So really, it tells you what the management is, it tells you what the inheritance is, it tells you what the screening is, what causes it. So I would refer that as a reference, and another reference, I'll put it in the chat again. Those are really helpful sources for you. Any other ideas? Should you have ideas?
Well, most of the stuff is Google related, so you can Google those conditions and you'll find support groups from parents where you can give that information or a support group information to the parents, and they can go and register there and read about it. So they don't feel alone, they feel part of the community. So that's also very helpful for parents to understand.
That's a good just while you're talking on that, before you go on to your next point, with the support groups, there's also Facebook groups. Just keep in that mind too. Go ahead.
Right. Right. No, that's pretty much it. So basically, you search करते हैं उसके बारे में and you just read about it and you. But what we in our, you can send some information to the GC in Pakistan at gmail.com if you have certain patient that you really don't know what to say to the patient, or it's a very rare condition and you need our help. We have genetic counselors on our team. We have geneticists. We have laboratorians on our team. So somebody can, pitch in and help you, and we can maybe be able to talk to those patients if we have some time and we can set up a time. So we are available here to help. We are not doing this for money. We are just doing it to help the Pakistani population and bring genetics to Pakistan. And of course, we all have our day jobs, and we do, work in the evening or on the weekends to do these telegenetics clinics. But we are available to help you, guide you. So send us an email. And also, go to those resources and maybe get information.
Yeah, and I was just gonna add that, genetic counseling is a very unique career opportunity. It's a path that is unlike any other. The training that we receive is unlike any other. जैसे कि अब मैं मुझे कोई कह के कोई आप जेनेरिक काउंसलर हैं, आप मेरी हार्ट सर्जरी कर दें, तो मैं उनको कहूँगी नहीं भाई मैं हार्ट सर्जरी नहीं कर सकती, मेरा वो काम नहीं है। इसी तरह जो जेनेरिक काउंसलिंग की जो फील्ड है उसको अगर डॉक्टर करेंगे तो हो सकता है ऑना पौना अच्छा कर दें, लेकिन जो प्रोफेशनल हैं वो प्रोफेशनल हैं और उनकी पाकिस्तान में तरबियत होना भी बहुत ज़रूरी है, उसके लिए हम काम कर रहे हैं। तो I would say that, you know, there are a few things, there are resources that are available online, but a professional is a professional. So again, like I would say, feel free to give us an email and shoot us an email, and हम आपके सवाल के जवाब देने की कोशिश करते हैं. Okay, well, this was lovely.
One thing, Aisha, I just want
Yeah.
to say, अगर आप लोगों को बाद में कोई सवाल आए और you haven't asked that right now, or even if we have answered some questions that you're not satisfied with that, so then again send us an email and I'll be happy to address that in a way that you want it to be addressed.
Right. And Mila is sending some things on the chat box also.
Yeah.
Again, lastly, but not the least, please fill out the Google form. That's the only way that we're keeping track of कौन in lectures में आ रहा है, कौन हमारे से बातें करना चाह रहा है, तो ये सारी चीज़ें हम बहुत ज़रूरी हैं. इसके अलावा मैं बहुत बहुत शुक्रिया अदा करना चाहूँगी डॉक्टर अहमद का और माइला का और हमारे को स्पॉन्सर्स JSME आना का और Health Sciences University Lahore का आपकी participation का बहुत बहुत शुक्रिया, and please stay tuned for more upcoming events like this one. And we're going to log off. Khuda Hafiz.
Thank you.